So intro to medical gases and oxygen storage. So this first slide here, we're just looking at some of the gases that you guys are going to come into contact with, that you guys are going to see in the hospitals and also in lab. So oxygen being one of the main ones that we work with. Big takeaways for oxygen. It is a medication. When you are in the hospital and you guys have had a chance to either plug in the flow meter or hook up devices to oxygen, that's 100% oxygen that's being delivered from the wall, or you could have it delivered from a tank or a concentrator or other devices that we're going to talk about. Why it's important to know that it's a medication is it really just is fixing the symptoms of hypoxemia or other underlying conditions, treating the symptoms, not the cause. So we as respiratory therapists always have to be thinking about both. If you have a patient that's going up in oxygen, it's really our job to think about why and try to fix the problem so that hopefully we can get that patient back off oxygen. The other gas that you guys are going to come into contact with a decent amount is just medical grade air. So at Gunderson, if you look at the wall outlets, we have an oxygen wall outlet. We also have an air outlet that allows us to deliver nebs just on room air. It also allows us to hook up vents and blenders and different devices that you can get a mixture of air and oxygen for a precise FiO2. At Mayo, I think they only have the oxygen piped in and not medical room air, which is fine. Their devices have different ways of kind of proportioning that FiO2 that we're going to talk about more in lab. You guys are going to get familiar or see, hopefully, Heliox. And what Heliox is a mixture of helium and oxygen. 70-30 or 80-20 are the big ratios used with that. Those are generally the mixtures that you see. And we're going to talk about the therapeutic usage of that on a different slide. But basically, it's something that we use for patients who have airway obstruction or severe bronchospasm, asthma attacks. And these would be patients with like severe respiratory compromise that we would consider using Heliox for. Carbon dioxide, this is another gas that you guys are familiar with for a couple reasons. It's definitely one of the things that we look at a lot in blood gases. It's what we're exhaling. It's a big source of how we monitor ventilation. It's also used in calibration of medical equipment. Nitric oxide, which is something that you guys probably haven't heard of yet. It has an important use with neonates that we're going to kind of go into detail with later. And then nitrous oxide, which there's a typo on this slide that I'm noticing right now, has 2 nitrogen atoms and 1 oxygen atom, which you guys are not going to have to write out the chemical components of nitrous oxide. The only reason I'm including it on this slide is because very commonly when people are talking about nitric, they confuse it with nitrous. So it's just a way to help you realize that it is not the same thing. Nitrous oxide is a laughing gas used by dentists. Nitric oxide is something that we use in neonates to treat pulmonary hypertension, and we're going to talk about that a little bit more. For laboratory gases, not therapeutic gases, we have nitrogen, and this is something that we use as a control for the atmosphere to kind of calibrate lab equipment. That's literally all you need to know about nitrogen. Again, I had mentioned with CO2, we obviously understand it from a lot of different components of like blood gases and ventilation, but it's also used to calibrate our blood gas analyzers to create the benchmark for evaluating a patient's CO2 levels. It also is used in heart-lung machines. So they use straight CO2 off a tank to keep internal organs inflated during surgery. So not a usage that obviously respiratory therapists really come into contact with, but that is a gas that we are familiar with. Helium, not heliox, helium, just straight helium, is used in the pulmonary function lab to help to measure residual lung volume. You guys don't have to understand the process by which they use that, but just kind of understanding that that is a gas that is used in respiratory therapy that you at some point, if you got a job in a clinic, might be responsible for utilizing. So medical grade air, big takeaways on all gases that we're using, they have to be dry. There cannot be any humidity in any of these gases. Reason being is if you have humidity and it's going through a ventilator or a blender or a compressor, all these different things, you're going to see that equipment fail because of that moisture. You can't have any oil, no particulate matter. It has to be like very, very clean and filtered air for basically equipment purposes. This is an example on this slide of an air compressor, and this is something that a patient who had home nebulizers would go home with, and this is how they would run them. The other place that we use them is in areas in the hospital where we don't have piped in oxygen readily available, like behavioral health only has a few rooms that have piped in oxygen, so we use an air compressor to run our nebs over there. I put this little note in here about not confusing compressor with concentrator because we're going to be talking about concentrators as well. And I had noticed previous classes would sometimes confuse them on exams. So a compressor is just compressing air to make it more pressurized. A concentrator is a totally different thing, and that's going to be concentrating oxygen or FiO2, and we'll talk about that as we move through. So again, nitrous, the only thing that you guys need to know is not to confuse it with nitric. You're not going to be tested on nitrous oxide in any capacity. I just mention it because commonly people will accidentally say nitrous oxide instead of nitric oxide. We use nitric oxide. Nitric oxide is a therapeutic gas that's used as a respiratory pulmonary vasodilator. So if you guys can think back to cardiopulm, which I know was a long time ago, we talked about obviously like the pulmonary circulation. So when blood leaves the right side of the heart, it wants to go into the lungs. When it goes into the lungs, it's deoxygenated and it's going into the lungs to pick up that oxygen, then travel to the left side of the heart and out to the body. So in some of our premature babies, they have what's known as persistent pulmonary hypertension or pulmonary hypertension. And what that means is the pressures of their pulmonary vessel are too high and it's almost blocking blood flow from getting into their lungs. So no matter how much we're trying to ventilate them or oxygenate them, it's not happening because the blood is not getting into the lungs very effectively. And if you can remember again, our pulmonary circulation should be very low pressure. And the reason it should be nice and low pressure is you want that large blood volume to easily go from the right side of the heart into the lungs, gather up that oxygen, and be able to be transported to the body. So what nitric oxide will do, or what we do with it, is we put it into either their ventilator or whatever oxygen device they're on, and that nitric oxide gets into their bloodstream, and it like locally will vasodilate their pulmonary vessels. And when it relaxes those pulmonary vessels, it makes it so that gas exchange can now occur. It's only FDA approved to do this in the persistent pulmonary hypertension of a neonate, although you can see it used off-label for adults. It's generally very low doses, 2 to 80 parts per million. You guys do not have to memorize that, but usually it doesn't take very much. And if this is what is going to help the baby, you'll see it right away. Heliox, which we talked about on that first slide, is a combination of helium and oxygen. The reason that this ends up being a good therapeutic gas is second to hydrogen, helium is the lightest gas. So big takeaway here is pure helium without oxygen does not support life. This is an important takeaway because if you don't have it mixed with oxygen, this is not something you should be giving to your patient because they will die. Seems simple. There's been a lot of anecdotal stories of patients that have been hooked up to the wrong tank where it was just straight helium and it did not go well for that patient. So Helix mixtures are always generally 70-30 or 80-20. The 70 and the 80 are what represents the helium, and the 30 and the 20 is what is representing the oxygen. The reason that you want the helium to be the larger percentage of this mixture is because the lightness and the size of this gas are what make it therapeutic. When you have patients that have really severe asthma or really severe post-extubation stridor where the tissues in their upper airways are really, really swollen, or they have a lot of inflammation or incredibly severe bronchospasm, what can happen is the driving pressure required to get oxygen into their lungs and the turbulence of oxygen is so much that it can't make it through these small little airways that either due to inflammation or bronchospasm have kind of clamped down. Helium, because it's small and very, very light, is a more laminar flow. It doesn't need that much driving pressure, and it can kind of wiggle its way through those small passages. If you start to get much more than 30% oxygen into the mix, because let's say your patient is hypoxic, the Helix mixture starts to be less and less effective because now you're introducing more and more of the oxygen atoms, which are larger. And if you have those larger molecules, essentially what you're doing is you're creating that more turbulent flow again, and you're not getting past those obstructions. So in 10 years as a therapist, I think I've used this probably 8 times. This is not a high use situation where you would deliver Helix to a patient, but we definitely have had those situations where we've had a severe asthmatic, we can't ventilate them, nothing is working, so we try Helix, and I have seen it be effective in kind of circumventing that airway resistance and getting some airflow to parts of the lungs that are just closed off due to either bronchospasm or inflammation. So oxygen safety, we're going to talk a ton about oxygen safety in lab. We're going to go over the tanks and all the different things, but big takeaway is oxygen flammable or not flammable? Oxygen is considered oxidizing, which is basically means it supports combustion. The 2 factors that influence its burning speed are the concentration of the oxygen. So sometimes you have somebody on, let's say, 40% oxygen versus 100% oxygen. The person on 100% oxygen is going to have more of a combustible kind of risk than the person on 40% oxygen. And then the secondary effect is the flow. So how much oxygen is flowing into the area also determines how combustible it is. So there's a couple situations where this becomes very, very relevant. You have a lot of COPDers that have oxygen at home that they wear continuously. A good proportion of those COPDers still smoke. It has definitely happened where I've had patients come in that have forgotten to take out their nasal cannula, they've lit up a cigarette, and conversely have set their face on fire. So this ends up being part of your education when you're sending people home with oxygen. There's a lot of other things to consider with oxygen safety, a lot of which we're going to go over in lab, but just understanding that oxygen is an oxidizing gas. It supports combustion. We have to be aware of that. 2 methods of oxygen production. I'm going to go through these pretty quickly because you guys don't actually have to memorize how the oxygen is produced. The only reason that it's relevant is because we're going to talk about concentrators, which are used for home use, and then we're going to talk about gas and liquid oxygen, which is more relevant with that fractional distillation. So for the physical separation, you basically have a molecular sieve. You can almost think of it as like a filter. So a concentrator is going to pull in room air. It's going to basically filter out the other gases so that the only thing that is left is essentially oxygen. And that's going to concentrate that oxygen down to allow people to have oxygen at home without hopefully having to use tanks, which is a big benefit for people. If you think about somebody, this is a picture of kind of what a concentrator looks like. If you think about people who have to wear oxygen all of the time, lugging around aluminum and steel tanks that empty out at a certain time interval, usually it's around 4 to 5 hours, you could end up bringing anywhere from 5 to 10 tanks just for a simple day trip. When you have these concentrators, they're pulling in room air, concentrating that oxygen, delivering it to that patient, and then they're only really limited by like their battery power, which a lot of them have a 12-hour battery. So when concentrators started getting covered by insurance and became more readily available to patients with home oxygen, it really helped quality of life for people who are on chronic oxygen. They were able to travel more. They had the freedom to do things that previously they weren't able to do because tanks are a real limitation. They're heavy, they're bulky, There's a lot of safety associated with them because it's a compressed gas. Here you have something that's pulling in your room air, concentrating that oxygen, and you just have to make sure it's charged. So concentrators, again, not a compressor, concentrator, concentrates down that oxygen and delivers it to the patient. This is just another reminder. So this is a couple pictures of compressors. This is going to be compressing air to make it more pressurized. Concentrators are concentrating oxygen. Just really separate them in your mind. I know it seems like I'm overkilling here, but I feel like it's easy on an exam to do a weird thing with your brain. So just make sure that you have those kind of separated in your mind. For the fractional distillation of liquefied air, I just want you guys to know this slide is really the only thing that you need to know about that. I have the process on another slide. It's just for people who are curious. I don't know who those people would be, but it's not something you guys are required to know. So all you guys need to know is it's the most common method. You don't even really need to know that it's least expensive, but it is. It does yield a gas or liquid. So you have two different ways of storing oxygen and delivering oxygen. You have gas and liquid oxygen. We'll talk more about that as we go through here. Big thing is oxygen is regulated to maintain a purity of greater than 99%. This is important. It's a medication. So what agency regulates the purity of oxygen? You're going to be looking at your FDA, your Food and Drug Administration, and your USP, United States Pharmacopoeia. When we get into lab, we'll look at where the labels, like the proper labeling and content, we'll look at the tanks and you guys can kind of see those stamps, but those are the regulating agencies for that. It is medication. It does have purity standards. Definitely know that. I'm literally going to skip this slide because you guys do not need to know this. Okay. Oxygen storage for gas. So again, fractional distillation yields either gas or liquid oxygen. So when we're talking about gas, we're talking about tanks or cylinders. They can be steel or aluminum. They require a regulator. This is a lot of stuff. I'm going to kind of whiz through it because we are going to look at it in lab, and that's going to be the bulk of what we do in lab. So I don't want you guys to worry too much about not being able to envision a regulator. We're going to go through it. But basically, the primary function of a regulator is to reduce the pressure of the gas coming from the tank to a working pressure. Remember that the working pressure is 50 psi. That should go on a flashcard. That is always the working pressure. And what that means by working pressure is it has to be 50 psi to be compatible with almost all respiratory equipment. The other thing a regulator does is it controls the flow of oxygen to the patient or to the device. When you're talking about oxygen storage as a gas, you're talking about it being measured in a unit called PSI or PSIG. The only reason that I have two is I've seen it both ways on the boards. In my exams, I'm sure I write it both ways. So all it is either pounds per square inch or pounds per square inch gauge. It's the same measurement. There's no conversion. It's just abbreviated different. And the reason that we are taking the time to highlight that is because when you're talking about oxygen storage as a gas, pressure is equal to volume. So pressure equals volume. So when you're looking at your regulator gauge, which is a pressure gauge on there, and it says 2200 psi, it means your tank is full. So no matter what, 2200 psi is a full gas tank. So if you have a half full gas tank, it's 1100 psi. So pressure equals volumes when we're talking about these tanks and cylinders. So this is an example of what we have at Western. So these are what you would call a cylinder manifold tank bank. And what that means is, let's say it's running off this side. So all these tanks are going to be open. All this gas is getting pumped in through these risers into our lab. When these tanks get empty to a certain pressure, and it has a system in here that recognizes what pressure it gets down to, it switches to this side where it runs off these tanks. It starts alarming. Someone comes and replaces these tanks. So there's always the tanks that are running and then the tanks that are full as a reserve. So that makes it an alternating manifold system. And that's what it means by alternating. So the oxygen's getting put through these risers up into our lab. And then we also have these horizontal zone valves. And I will show you where they are in our lab. I will also show you where they are at the hospital with clinical. The reason that we care about zone valves is one of our responsibilities, if there is a fire, is to go and shut off the zone valve for oxygen. And again, circling back to oxygen being combustible, if you have a fire and you also have oxygen being pumped into that area, it's not a good idea. It's going to create an explosion. So we have these safety shutoffs so we can hopefully minimize the damage of a fire in an area that has oxygen. So this is just looking at the anatomy of a cylinder, just so you guys kind of have an idea in your head of what we're talking about. For our purposes, we are only going to worry about H tanks, which is the largest tank that we have, E tanks, which is probably the most common tank. This is the tank that you see at both hospitals for transport. This is usually what you see people bring from home. And then we're also going to look at D tanks. You're going to have to know the conversion factors for them, which we'll talk about later, but these are the three. All these other ones you don't have to worry about. So just H, E, and D. I also want to highlight here, because we're going to talk about it later, these are the valve stems, okay, when they're talking about valve stems. But again, this is a lot of stuff that we're going to look at in lab and in the next PowerPoint. So the second way that we store oxygen is liquid. So we talked about gas, which is in those tanks. The other way that we can store it is as a liquid. So liquid oxygen can be stored either as a bulk, like for example, for hospitals, they have huge storage containers for bulk liquid oxygen that then gets piped into their each individual hospital rooms, or it can be small and portable. There's very, very small little liquid oxygen tanks that patients can use, and there's a benefit to that in the sense that liquid oxygen, a little goes a long way, and we'll talk about that when we talk about like the math of calculating tank duration. But for right now, just know that it can be bulk or it can be small and portable. Liquid oxygen is abbreviated LOX, just for future reference. And then the big difference is with gaseous oxygen, when we were talking about gas tanks, we talked about pressure equaling volume. Pressure does not equal volume with a liquid. And the reason why is if you have half full liquid here, it's going to have gas vapor pressure above it, right? Here, the liquid's a quarter full. It still has the same gas vapor pressure. Here, it's almost completely empty, but the gas vapor pressure is still present. So you can't use pressure to measure the volume of liquid oxygen because the gas vapor pressure stays present all the way to the end. So what we use instead is the weight of the liquid to measure volume. So weight of the liquid oxygen is equal to volume. This will kind of make more sense when we start doing the math associated with this, but just so you guys have a heads up, that's what we're looking at there. So again, you guys do not have to have this memorized. The only thing that I want to draw your attention to, especially for people who are visual, is you almost have like a thermos-like container. You have your liquid oxygen here. It gets drawn up through capillary tubing. It's going to go into what's called a vaporizer coil that's going to warm it up to its gaseous state, and then it's going to come down here to a pressure reducing valve, and that's going to take it down to that 50 psi, that working pressure, and it's always that 50 psi. This is an example of one of those small portable liquid oxygen tanks that a patient could use at home. So on this next slide, I show you the only thing I really want you to know is the purpose of this like vaporizer coil, understanding that you have to warm it from a liquid to a gas, and then really, really remembering that 50 psi working pressure. This is just another viewpoint of the same thing. Again, not anything you guys have to memorize or label. It's just for mental imagery of kind of what's happening. These regulating agencies for therapeutic gases, you guys are responsible for memorizing. The Department of Transportation, that's going to be your tank manufacturing, storage, and transport. Your Compressed Gas Association, that's going to provide standards for storage of different gases and tanks and how they want you to do it. They also designed the safety systems for compressed gas, and we're going to talk about these more in the next PowerPoint, but this is safety systems that are designed to prevent a misconnect of basically a regulator to a particular tank. So basically, if you're trying to deliver oxygen, only an oxygen regulator will fit on an oxygen tank. So it helps to reduce someone potentially giving the wrong gas to the wrong patient. And you'll get a chance to look at those in lab. The National Fire Protection Association, that's an independent agency that provides guidelines for, again, the safe storage of bulk oxygen. Again, this is an oxidizing agent. It has the capacity to explode, especially when you're talking about the gaseous version that's like under a lot of compression. There's a lot of safety standards that have to be taken into consideration when you're talking about these things. The Joint Commission, the only thing you really need to know about the Joint Commission is that they're an organization that comes into hospitals and other facilities like that, and they just make sure that we are compliant with all of the standards that these other associations lay out for us. And if we're in breach, we get in trouble, and they kind of just come in and check up on us. This is an example of a large bulk liquid storage. So for Gunderson, we have this large container at Gunderson, and this is where our liquid oxygen is. This small tank next to it, and the reason I'm highlighting it is because it kind of qualifies under those safety regulating agencies, is this is considered our reserve oxygen tank. So if for some reason the larger tank malfunctioned or something happened to it, essentially the smaller tank has to be there, and you have to have enough oxygen for your average patient load for 24 hours. And so that gives you the time to get this one up and running. So anytime you have a facility with like a large oxygen storage like this, they always have to have a reserve tank under those guidelines. And that is pretty much it for this PowerPoint.